Recording in progress.
Hello, good evening, everyone. So I welcome you to the Indian Academy Head and Neck Surgery webinar series. This is a sixth in the series on contemporary ENT practice organized by IAOHNS along with GSK. Today, we have chosen an interesting topic, and it is on snoring and sleep apnea and OSA. We have Dr. Vikas Agarwal from Mumbai to moderate the session, and eminent panelists from all across India. And we have Dr. Kenny Pang from Singapore to deliver the keynote address, and he shall be talking on ESP and update and evidence-based medicine in OSAs. And I hope you'll all have an enriching experience. I hand over the microphone to Dr. Vidyasagarar, the president of IASSA, for taking this program forward. Thank you very much.
Good evening, everyone. At the outset, I would like to thank the IAOHNS for giving us, not just me, but the entire IASSA, this platform for this week of IAOHNS webinar series on snoring and obstructive sleep apnea. And today we are going to have a talk by none other than an eminent speaker, Dr. Kenny Pang, as well as a panel on OSA by Dr. Vikas Agarwal. Surgical management of obstructive sleep apnea has seen a world of change since the day Fujita introduced the surgical management of snoring and sleep apnea in the form of UPPP. Since 1996, after the meta-analysis of Sher et al., there has been a sea of change or a tremendous change in the surgical management of obstructive sleep apnea. And those changes actually changed the surgical success rates from what it was reported by Sher et al. As 40% to almost close to 80 to 88% by various eminent authors. And today, we are going to have one of the best surgeon who was instrumental in bringing about this change of the surgical success from 40 to 80 or 88% in the selected patients. And as the president of IASSA, it gives me immense pleasure to introduce none other than Dr. Kenny Pang. Dr. Kenny Pang is the director of the Asian Sleep Center in Singapore. He has done double FRCS, one in Edinburgh as well as in Ireland. He is also the founder member of the Asian Sleep Surgical Society. He is also the founding member of the International Surgical Sleep Society. He is also a member of American Academy of Sleep Medicine, member of Singapore Sleep Society, member of World Sleep Society, board member of Italian Sleep Disorders Board, member of British Association of Sleep Surgeons, and member of European Academy of Sleep Medicine. And he has more than 60 articles that has been published in the peer-reviewed journals, and which there are very, very many articles that are so important in bringing the sea of change in the literature concerned with our surgical management of obstructive sleep apnea. One of them is obviously the sleep goal article published along with Dr. Rottenberg. Another important article that I would say is the trends in CPAP adherence over 20 years of data collection, that he has done a big, tremendous work to show us what exactly is the real adherence of CPAP. He has also had the articles on predictors of difficulty in intubation with the patients with OSA. And more importantly, he is one of the pioneers who was instrumental in creating the expansion sphincter pharyngoplasty. And today, it gives us immense pleasure to listen to him on the update of surgical management of obstructive sleep apnea, especially on expansion sphincter pharyngoplasty. And without further ado, I would hand over the session to Dr. Kinipang. Thank you, sir. You can proceed, sir.
Can you see my screen?
Yes, we can.
Thank you very much. First of all, I'd like to thank the Indian Academy of Otolaryngology, Head and Neck Surgery for giving me this honor of speaking tonight. I will start off by talking a little bit about the expansion pharyngoplasty and some evidence-based in sleep apnea. It's so nice to see old friends again. It's been so long since we caught up. We must catch up soon, actually. Yes. Okay, I have no financial disclosures. We know that sleep apnea surgery is not the UPPP, as Fujita had first introduced in 1960s. So that's extremely archaic and we don't use them anymore. We know that the palate variation varies from patient to patient, just like double eyelid surgery or rhinoplasty, where every patient deserves a different type of surgery based on the anatomy and the structure, morphology of the palate, because we don't want to get palatal stenosis or uvular velopharyngeal stenosis at the end of the day. So this is one of the most feared complications after UPPP, which is nasopharyngeal stenosis, which is very difficult to treat. So I'd just like to touch on the expansion technique. The expansion technique, actually, we published it in 2007, is basically treating the lateral pharyngeal walls, because before that, the lateral pharyngeal walls was something that was completely neglected. We knew that the lateral pharyngeal walls could be bulky and collapse a lot, but we didn't know how to tackle it or how to treat it. So this was inspired by Cochlear. We looked back at all the old literature and data to try to figure out how do we better treat the lateral pharyngeal wall. And we found this article in 1959, written by Cochlear, where he described a dynamic muscle sphincter. Basically, what he used is the palatopharyngeus muscle in the midline to close it off. And it was Christel in 2003 who called it the sphincter pharyngoplasty, and he called it the dynamic sphincter. This was basically used in patients with cleft palates. Let me just show you. Basically, patients with cleft palate, what you can do is use the palatopharyngeus muscle and stitch them down so as to narrow off the velopharyngeal space. We thought that by actually narrowing, we can actually use it to expand the velopharyngeal space. And that's where the expansion sphincter pharyngoplasty was coined. If you look at the anatomy, you know that the palate anatomy, most of us would know, is made up of vertical and horizontal muscles. There are 3 vertical muscles and 3 horizontal muscles. The superior, middle, and inferior constrictors, the palatopharyngeal, salpingopharyngeal, and the glossopharyngeal muscles. So this surgical technique is basically trying to debulk the lateral pharyngeal walls and to create a simple technique with not too much complications, anatomically sound, low morbidity, and so that all of us can practice on our patients, and something that is efficacious as well with very low morbidity. So basically, we start off by doing tonsillectomy. I think most of us would have already tried the expansion sphincter pharyngoplasty technique on your patients, and you realize that it's actually pretty simple to do, doesn't need much technique or special instruments. So this is done under ideal conditions, also known as general anesthesia. You can see that this is the palatopharyngeus muscle, which is also the posterior pillars of the tonsil. A tonsillectomy has been done. The idea is to identify the palatopharyngeus muscle and try to cut it or dissect it horizontally as inferiorly as possible. These patients actually have very bulky lateral pharyngeal walls. So identifying the palatopharyngeal muscle is actually quite easy. So the idea is to not to buttonhole the posterior tonsillar pillar, but to cut transversely as low as you can, if you like, to try to rotate the muscles. You notice that you try to keep some attachment of the palatopharyngeal muscle posteriorly, so that when you pull, you can see the tension that you create laterally, anteriorly, and superiorly. I actually make a cut on the anterior surface of the palate. You could do the functional expansion technique, which is basically to tunnel your sutures beneath these arching fibers of the anterior palatal, soft palatal region. You can see the anterior fibers here. So what I do is I actually make a cut here, because I pretty much like the scarring, so that it kind of pulls the palate laterally as well. And I use a Vicryl 4/0 round body suture, and I make a figure of 8 stitch onto the palatopharyngeal muscle itself, like so. And I take it, let's see, and I stitch it. I put a finger behind the soft palate and feel for the hook of Hamulus. That's the angle you want to go. So can you see the lateral, superior, and anterior pull? Sometimes if you feel that it's not strong enough, you can take multiple bites or sutures onto the palatopharyngeal muscle, stitching it anteriorly, superiorly, and laterally as well. So basically what I do is I tie it down. And if you don't like it, like I said, you can actually take multiple sutures and stitch it. You can tell that I'm not really a uvula lover, although I'm aware that there are functions of the uvula. So if the uvula is bulky, sometimes I do remove them, but I nowadays tend to trim it smaller, forming a neo-uvula than completely transecting it. So these are patients who this is a patient who already had a tonsillectomy done previously. And these are patients with still bulky lateral pharyngeal walls. You can see them here. So what you do is you can dissect and look for the palatopharyngeal muscle. And by default, because these patients have a very thick lateral pharyngeal wall, you can see that the palatopharyngeal muscle is actually quite easily identifiable, okay? So you truncate it as low down as you can, and you use a figure of 8 suture. I use Vicryl 4/0 round body, and you can stitch it laterally, superiorly, like so, okay? So we found that the success rate of this is our first clinical trial that we did. The success rate was 82.6% with AHI less than 20 and 50% reduction. The average follow-up was about 6 to 9 months. Claudio as well as Filippo, we did a joint study on patients with the expansion technique. We compared it with the UPPP together with the TORS, tongue-based surgery. We found that the actual reduction, let me just show you, there you go, was AHI of 9 post-operatively compared to 19 in the patients with the UPPP technique. So we matched these patients, 24 patients, matched with age, BMI, AHI, gender, and other comorbidities, and we found that the ESP technique, the expansion technique, was way more advantageous, as efficacious as well. Giovanni came up with the functional expansion technique, and he performed it on 85 patients, and he found a 89% success rate. And this was a 3-year follow-up. So this was actually quite a long-term follow-up as well. Second, from Texas, actually performed the expansion technique on children, and they matched 25 children who had the expansion technique versus the traditional T's and A's, adenotonsillectomy, and they found that there was persistently good results for the modified expansion technique compared to the T and A group. Okay. Marina did a study on 53 patients, matched as well with the UPPP Z-plasty, lateral pharyngoplasty, and expansion technique. And she found that the highest success rate was the expansion technique at 90% success rate. Okay. We ourselves did a meta-analysis, and this was published in 2015. And we found that the expansion technique the success rate ranged from 80 to 90% at 82 and 89% as well. And we did the forest plot for this, and we found that the success rate favored the expansion technique compared to the UPPP technique. Okay, so I'm just going to plow through some data on the long-term results of the expansion sphincter pharyngoplasty. This is 1 year results, and they found that the Epworth Sleepiness Scale sustained even after a year. The visual analog scale for snoring also sustained and was pretty good, as well as the AHI after 1 year long-term results. And you can see that these patients benefited quite well from it. So then comes this perennial question of what do you do with patients with circumferential velopharyngeal collapse that you see on DICE? We looked at 73 patients, myself and Octavio from Italy, and we actually found that we performed the anterior palatoplasty as well as the expansion sphincter pharyngoplasty in all these 73 patients, and we actually found a success rate of 86.3%. These are patients with concentric velopharyngeal collapse, both seen on Muller's as well as DICE procedure. Okay, just get this moving forward. There you go. So we found that the success rate range between mild to moderate and severe sleep apnea. We found that the success rate was better for mild, followed by severe, and then the moderate group. Okay, because our preoperative protocol was different, we found that those patients who had no DICE did just as well as those patients who had preoperative DICE evaluation. And we found that patients who had additional nose surgery together with palate surgery actually had a 88% success rate compared to those patients who only had palatal surgery alone. I will also present some data on nose surgery in obstructive sleep apnea, multi-level surgery at the end of this talk. Okay, so Guillermo from Spain actually looked at 75 patients who had the expansion technique done, and this was a multi-center study that was recently published, and they found that the expansion technique had very good sustained efficacious result post-operatively. A systemic review and meta-analysis also for all palatal surgeries for the treatment of obstructive sleep apnea. They looked at 52 articles that was available in the medical literature. And I just want to show you, they looked at all the various, I don't want to plow through all the data, but they looked at all the various palatal pharyngoplasties out there, and they found that the expansion technique overall had the highest significant success rate. Okay, I don't want to brush away all the other palatal pharyngoplasty techniques as well. I just want to show you this very elegant study just published about a year and a half ago. This was done by Shairat from Thailand, and he looked at 4 studies. This was a meta-analysis that compared the barb repositioning pharyngoplasty versus the expansion. I'm sure some of you do the barb technique as well. And he looked at the meta-analysis of all these studies, and they actually found that the success rate was very similar at 84 and 79% respectively for the barb and expansion technique. It was statistically not significant, the difference, but I just want to show you a little bit about all 4 of these papers. There was significantly lower AHI reduction as well as apnea, as well as Epworth Sleepiness Scale. AHI decreased more for the barb technique, although it was not statistically significant. And studies also show that the expansion and barb technique both improved the AHI as well as the Epworth Sleepiness Scale. Okay, the success rate ranged from 80 to about 86% as well for both groups. Okay, so this is the $1 million question. We want to figure out whether not just CPAP, but whether upper airway surgery itself actually reduces blood pressure. Okay, so we took the task upon ourselves to look at 112 patients with sleep apnea and hypertension. Okay, so all these patients had either nose, palate, or tongue surgery. We took all comers and we looked at the pre and post-operative blood pressure results. Okay, this is what we found. This is very interesting results because we know that perennially it's always been said that CPAP reduces blood pressure, but how about surgery? Okay, so all these patients actually had the expansion technique done together, multi-level, together with nose and or tongue surgery. You notice that most of them were severe apnea patients because it's intuitively, you know, patients with severe sleep apnea have higher tendency of hypertension. So we had 112 patients, okay? So we looked at the reduction in systolic and diastolic pressure. We found that there was a reduction between 11% to 18% of blood pressure, systolic and diastolic, okay? And this was all comers, AHI from 5 to more than 30, okay? So all comers for sleep apnea. This was a mean follow-up of 16.1 months. So this was actually quite significant in the sense that the mean reduction of blood pressure was between 11 to 20 millimeters mercury, okay? But I just want to highlight one point. You notice that their BMI dropped from 27 to 25. Most of them, we are very strict with dietary control. So we get them on a very strict low carbohydrate, high protein diet so that they can lose some weight. And of course, if they can, some form of exercise, okay? So you notice that these patients actually drop their BMI as well. So we look at the Cohen's effect of BMI on the blood pressure at the end of the day, okay? So anything less than 0.5 is a small effect. So we found that the systolic and blood pressure, the Cohen's effect of BMI on blood pressure was less than 0.5. What does that mean? That means that the blood BMI did not affect blood pressure reduction at all, okay? So moving on, we need to talk about some evidence-based medicine in sleep apnea because we know that, as Sergal has mentioned, we have moved forward in the line of teaching in terms of sleep apnea management. We have moved away from CPAP, we've moved away from the traditional UPPP to more anatomy-targeted surgery, including the expansion, the BARP, the lateral pharyngoplasties, and whatever we have, okay? I just want to show you how it evolved with time from the 1990s till now, 30 years, 32 years of surgical intervention, okay? So we know this landmark paper, this is by Ed Weaver. I don't want to bore you with this, but 18,000 patients on CPAP, 2,000 patients who went through UPPP. We know that patients who had CPAP actually died faster, okay? We know that patients who went through the UPPP actually live longer. Intuitively, you will say, hey, you know, but as surgeons, you will choose better patients for UPPP, and those that are not fit for surgery, those with more comorbidities actually use CPAP. But this study was controlled for gender, age, race, year of treatment, and all other comorbidities. So this was a very controlled and matched two-arm study, okay? So we know that patients who use CPAP actually had a higher hazard ratio of death, okay? And we know why, because of compliance, okay? This one we don't need to go through. So let's look at CPAP over from the year of 1994 to 2020, okay? So this is a study done by Brian and myself. We looked at first-line treatment for obstructive sleep apnea, okay? Bear with me. We looked at 82 controlled CPAP trials, 82 trials, and we found that, you know, the criteria for usage of CPAP is 7 hours per night and 7 nights per week. I mean, you know, most people sleep about 6 to 7 hours and you have 7 nights per week. The overall usage for these 82 papers was only 32.9%. That means 67.1% of patients do not benefit much because of the low CPAP usage, okay, which makes sense. Then we also looked at over 20 years, we collected data of CPAP adherence. That means how much, so-called the percentage used, okay? And you look at this data, you notice that it's what we call a flattened curve. That means since the duration of the 1990s, you notice that the patient non-compliance rate or the compliance rate has completely dropped, plateaued since the year 2000 to the year, 12 years from then. Okay, so we looked at 20-year results, and you know that CPAP technology has changed, right? From the manual CPAP to the automatic CPAP to the C-Flex to the BiPAP. And we know that technology has changed tremendously. The type of mass interface has also changed, but you notice that it has plateaued at about 30% compliance rate. So perhaps we should ask ourselves that it's not the CPAP that's at fault, it's the human, it's the patient who doesn't want to use it. So no matter how you change your CPAP technology, the CPAP usage is still going to be about 30 to 40%, which is actually quite dismal, okay? So we know that over the past 20 years, CPAP usage is not improving. But how about palatal surgery? Is palate surgery improving? Question mark. Okay, so this is the million-dollar question. Let's figure that out together. So this is the Aaron Scher's paper. You know, it was being quoted ad nauseum. He looked at all comers data from 1966 to 1995. He found that the success rate was a dismal 40.7%, 40.7%, which if you ask yourself is worse than flipping a coin, isn't it? At least flipping a coin, you have a 50% chance of getting either heads or tails, right? So this is bad. Then we look at IAOHNS data. So Adam did this study and presented it in 2007. He looked at 10-year study from 1996 to 2006. He found that the success rate overall for phase 1 surgery, which means soft tissue surgery, was 55%. So hey, it's improving a little bit. Then I did a 17-year meta-analysis, and we looked at all palate surgeries for 17 years from 2001 to 2018, okay? So we looked at 59 papers who documented palatal surgery with pre- and post-operative PSG or sleep study. There were 2,715 patients, okay? What does it say? Okay, so this paper showed that the overall success rate was 67.5%, which means if you look carefully, from 1995 that was published, the success rate was 40. It went up to 55%, and now it's at 67.5%. Okay, this is all comers. All comers means all types of surgery, okay, which is, you know, not that accurate because you got to look at the specific surgery for the specific patient. But let's just look at this paper, okay? So you notice that the number of UPPP surgeries done for this 10 years was 25% from 2000 to 2009. If you look at 2010 to 2018, the number of UPPPs done was 12%. That tells you something, isn't it? That tells you that ENT surgeons are realizing that the UPPP doesn't work, and we use them less. We use them less, okay? And when you use them less, your success rate actually might get better, okay? So the pooled success rate was 67.5%, okay? So we look at the forest plot, and we actually found that the change in apnea-hypopnea index, AHI, was best for the anterior palatoplasty and followed by the expansion technique, okay? So this study actually at least tells us that ENT surgeons have evolved with time and that our success rates are improving compared to CPAP, okay? So let's take a few steps backwards and let's look at whether or not CPAP actually improves or whether upper airway surgery improves CPAP usage, okay? Because, you know, some people say that after upper airway surgery, after palate surgery, you cannot use CPAP that well. Well, we know it's not true, okay? So this is 19 articles that was published, and this is meta-analysis. And we had 323 patients. We found that the average mean reduction of CPAP was 1.4% after upper airway surgery. And the mean increased usage of CPAP was 36 minutes. And there was no evidence of significant excess leak after palate surgery. So we know that the myth that people say that after palate surgery, you get more leak from CPAP is not really true, okay? Let me show you a landmark paper. This is, for those of you who are not aware, this is published like 5 years ago. This is a landmark paper published in the New England Journal of Medicine with the highest impact factor, okay? I just want to draw your attention to this study because it's one of the largest studies with an 8-year follow-up, 8 years, okay? So they looked at the CPAP group, 1,300 patients, and the usual care group. This usual care means that they basically just monitor the patients with no intervention. No intervention means no treatment, just follow them up, okay? Basically just continue observation, okay? With medication, of course. So we notice that they are all matched in terms of chronic disease, comorbidities, hypertension, stroke, heart disease, medications, as well as BMI and sleep apnea characteristics, okay? I just want to show you this. Look at this graph. At the end of 8 years, you notice that the incidence of myocardial infarction, strokes, hospitalizations for heart failure, unstable angina, and ischemic transient attacks is the same for the CPAP group and the usual care group. What does that mean? That means for a patient who uses CPAP, it's as good as not using CPAP at the end of 7 to 8 years, okay? That means that perhaps using CPAP does not have any survival advantage or any advantage in terms of preventing cardiovascular mishaps, okay? This is another paper published in Korea, okay? This is a paper who looked at 22,000 patients who underwent UPPP, which is palate surgery. This was only published like 3 years ago, okay? The numbers at 22,000 patients who underwent UPPP is very difficult to ignore, meaning that it's highly powered, okay? So I just want to highlight this graph. If you look at this graph shows you time after 8 years and the incidence of congestive heart failure. If you look carefully, the incidence of congestive heart failure patients who underwent UPPP were actually less compared to those patients who had no surgery and the control group, okay? Which means that there is definitely some form of survival advantage in terms of UPPP, okay? So this answers the next question that we have. Does nasal surgery in the multi-level approach actually improve success rate, okay? So the question is, does nasal surgery improve multi-level surgical outcome in sleep apnea? So that means that if you do multi-level surgery, if you add on the nose surgery at the same time, does it improve your success rate? Okay, so we looked at we did a multi-center trial with 735 patients. Okay, this was published last year actually. I just want to highlight to you some of the data. Okay, so you look at the nose group. This is the group who had some form of nose, palate, and tongue surgery, and there were 575 patients. And this is the group with no nose surgery. That means some form of palate surgery alone or palate and tongue surgery. Okay, so these are the abbreviations which I think most of us will understand. The million-dollar question is, did the nose group patients have better success rate? So if you look carefully here, the pre-op and post-op AHI, the nose group patients actually improved better than the group with no nose surgery done. Okay, and this was statistically significant. What does this mean? This means actually if you add on nose surgery to your patients who require multi-level surgery, they actually do better in terms of success rate, okay? In terms of Epworth Sleepiness Scale as well, okay? So your question to me is, why? Why is it that nose surgery actually improves the overall success rate when you're doing multi-level surgery, okay? So this was actually published by a Japanese group, just published about a year and a half ago, and in the Journal of Clinical Sleep Medicine. And this was a commentary made by Tucker Woodson and Garcia, okay? I just want to share with you, if you read carefully the title, it says, the collapsing anatomical structure is not always the primary site of flow limitation. Okay, I say again, the collapsing anatomical structure is not always the primary site of flow limitation. What does that mean? It means that the site of flow limitation, that means obstruction, may not be the primary collapsing site. Okay, what does that mean? Let me show you this. I always show this slide all ad nauseum in all my talks. Why? Because it explains the upper airway as a conduit, as a dynamic structure that pressures can change based on proximal obstruction. Okay, take a look on the left side. Okay, I hope you can see my little arrow pointer. Okay, so this is a normal person breathing. A normal person breathing would create an intrapleural pressure of -5 in order to suck air in, because you know inhalation is an active process, whereas exhalation is actually a passive recall process. Okay, so imagine if you have some form of obstruction in your nose, for example. If you have obstruction in your nose, you need to create a -30 negative cm water intrapleural pressure in order to inhale the same amount of air as a normal person with no nasal obstruction. So if you do that, you create a lot of negative pressure in your intrapleural space. You also create a negative pressure in your oral pharynx, That means that if you relieve the obstruction in the nose, the oral pharyngeal structures will not collapse anymore, right? And that is why the collapsing anatomical structure is not always the primary site of flow limitation. And that explains why this is true, because if you do nasal surgery in a multi-level setting, in one sitting, your success rate will improve tremendously, okay? So that explains why adding nasal surgery in multi-level surgery actually benefits the patient, okay? Finally, I would like to touch on sleep goal, because you know that we really need to move away from this so-called nebulous AHI that doesn't mean a thing to most patients, okay? Because you know that most patients don't come to you in a clinic and say, hey doc, my AHI is high. I want to treat my AHI. Nobody says that, isn't it? Okay. No patient comes to say that I'm having apneas, okay, and I have most likely 50 apneas per hour. They don't do that. They come with symptoms. Patients come to you with loud snoring. They come to you with excessive daytime tiredness. They come to you complaining that their spouses cannot take their snoring anymore. The cardiologist will refer you patients with uncontrolled hypertension. And these are the things that actually bother the patient or bother the cardiologist, and they are actually comorbidities as well, isn't it, right? So, and these are actually the so-called end organs of upper airway obstruction. Okay, what does that mean? So we looked at the sleep goal. Okay, I've just run through with you quickly. As for snoring, reduction of 50%, sleep latency increased by 50% sleep latency time. Epworth Sleepiness Scale, reduction of 50% in less than 10. Execution time. We look at the 5 main major criteria, which is P goal, okay? P for blood pressure, gross weight, oxygenation, AHI, and quality of life, okay? So these are the major criteria. I say major because they are the ones that are actually the end, so-called, can cause end organ damage and a lot of comorbidities, okay? So we wanted a more holistic approach rather than just one AHI, because you know that the AHI has a lot of shortcomings, which I don't have time to go into, but I think you know that the hypopnea definition is different. The sleep test can vary from night to night. Patients have a first night effect, and we know that sometimes patients don't do so well, especially when they drink alcohol that night as well. I'd like to thank my co-authors as well, because I think this is very important, because they spend a lot of time collecting these data. Okay, so we basically had 302 patients, and we looked at all patients with AHI more than 5 and all BMI. Okay, so these patients all had some form of multi-level surgery, nose palate or nose palate tongue surgery. DICE was not mandatory, but we looked at the P-goal as the major criteria and the SLEE as the minor criteria, okay? So let me just share with you some interesting results, okay? So we wanted the sleep goal criteria to be as stringent as the OSAS criteria. And all these 302 patients, based on the OSAS AHI criteria, there was a 66% success rate. Okay, so bear that in mind. We wanted to peg it to as close as 66% as we can. Okay, so some interesting results. We found that these patients with a drop of systolic and or diastolic blood pressure of 9 millimeters mercury, were 69% of these patients actually dropped their blood pressure, okay, which is great, right? Because we know that upper airway surgery actually reduces blood pressure, okay? We looked at gross weight reduction by 8%, and 40% of our patients actually dropped their gross weight, which is good, okay? Dropping BMI by 2 points, 44% of our patients actually drop their BMI, okay? We know that oxygen, the lowest oxygen saturation or lowest saturation of oxygen is just 1 point, okay? It's called LSAT. And we know that it's not that accurate. We prefer that the duration of oxygen level less than 90% is more important, okay? We looked at the reduction by 50%, pre and post-operative sleep studies, and we found that 72% of our patients actually dropped their duration of oxygen less than 90% by 50%, okay? So we know that the old criteria was 66% in these 302 patients. So we looked at the number, so we tabulated an algorithm or permutation to see which level is as good as stringent as the SHERS criteria. So we found that 2 major criteria plus 2 minor criteria, the success rate of this group of 302 patients, our study population, was 69.8%. That means this was good enough or as good as the SHERS criteria without just using one parameter called the AHI. Okay, so we stopped at this 2 major and 2 minor criteria. Okay, of course, we are looking currently, just before COVID started, before the pandemic hit the world, we were actually collecting more patients, and we are still collecting more patients. So all those of you who really want to collaborate with us in this study, please just, drop me a line or email me. I'm very Googleable everywhere. I'm on Google everywhere. So just Google me and please drop me a line, for those of you who have my email as well, so that we can at least collect more than 600 patients to make this a more robust and stronger study. Thank you very much. Are there any questions for me?
Thank you, Dr. Pang. It was a fabulous talk. We really enjoyed listening to this lecture. It was really informative, educative, and it is going to be what do you call, like a change of trend of management aspect in relation to the surgical management of obstructive sleep apnea. Let me ask my colleagues if they have some questions. If they have any questions, they can ask. If not, I do have 2-3 questions from my side. So first, let me ask some questions if any of my colleagues have it. Because Vijay, anyone?
So I would like to ask a quick question, Dr. Sagar.
Hi, Dr. Rahul.
Yeah, hi, Dr. Pang. Excellent talk. Always a pleasure to listen to your observations and the way you present literature. I just wanted to know your observation. If you have seen, is there any impact of the tongue position on your success outcome? The way, say, Friedman had described in his paper, have you seen that high tongue days kind of shows poor outcome, whereas a low or a flatter tongue suggests a better outcome in your palatal procedures?
No, in fact, I've been looking at this Morse criteria, the Morse type of tongue, right? And I'll share with you that the jury is still out in the sense that there is no fixed specific procedure that can address the 3 different types of Morse tongues, if you like. I cannot seem to find any specific procedure that works for any specific type of Morse tongue. And I also do not find any palatal procedure that can help any specific tongue shape or size or position. So I want to say that sometimes I feel that maybe that was an, too enthusiastic description of the tongue morphology. But personally, I haven't been able to find a good, way of classifying the shape of the tongue. Any comments? Maybe you have any comments on that? Vikas knows. Vikas does a lot of tongue surgery. Would you like to share with us?
Yeah, so basically in Friedman or Mallampatti, you are unable to see the base of the tongue. And the oral tongue does not contribute to sleep apnea. So I think the whole concept is a myth, because something which you're not seeing from the front, you cannot comment on that. And therefore, I believe you have to put in a flexible scope through the nose. DICE is the best, at least flexible scopy from the nose to look at the base tongue is very, very important. Looking at the anterior 2/3 of the tongue or the oral tongue does not take you anywhere.
Oh, let me ask a question, Kenny.
Hi, Sima. Yeah.
Hi. So, Kenny, I won't waste too much time with the usual compliments because they're always as usual. It's always wonderful to hear that. But, I like that presentation part where you mentioned that an expansion plasty with a barb plasty. Now, in an expansion, you're getting the palatopharyngeus to the pterygoid hamulus, whereas in a barb, you're getting it to the pterygomandibular raphe. And the difference in results is barely like 82 to 79%. So which puts me in a bit of a fix now is that how do I decide which one of these to choose?
I guess really it depends on which technique you're using, because I usually stitch towards the hook of hamulus because it's just easier for me. And the technique, my finger goes right to that direction and I can feel it and I just stick it to that direction. So yeah, I've done the barb as well. And I just find that it's just not as good as the expansion technique. That's why I'm just doing the expansion technique.
So it would be based on individual preferences about surgical technique.
Definitely, yes.
Perfect. Thank you.
Can I ask a question, please?
Of course.
Yeah.
So I just wanted to know from my knowledge that is there any article in the literature which will be comparing the surgical success or the effect of surgery on different parameters vis-a-vis CPAP?
The effect of surgery on CPAP. The largest study was the one I presented with 325 patients. That one showed that no matter what palate or no surgery you do, the CPAP compliance increases by 36 minutes.
No, sorry. My question is that the effect of surgery on the different parameters, like we have a sleep goal on different parameters, like you had shown in one of your slides that CPAP does not help in the longevity or survival rates after 8 years. So similarly, is there a study which shows that the surgery actually helps apart from the one you had described, which was just about UPPP, about the other palatal surgeries or a combined multi-level surgery?
Oh, no, not yet. No.
Not yet.
No, we need to do that actually.
Yeah. Okay.
All right. So I'll take on the question from myself. Dr. Pang, it was very enlightening talk, but I have a question myself. The question is going to be a little bit challenging in itself. See, traditionally, we always believed that all the patient, no matter what the collapse is, if it is dynamic collapse, we have to give a CPAP trial, followed by, if the patient is not tolerating, we should go for a surgical technique. But after listening to your talk, it kind of opens up the Pandora's box that we may have to go back of considering surgical treatment as the primary treatment rather than CPAP, because your surgical result is 67%, no matter whatever technique you choose, when compared to CPAP adherence, which is just 30 to 40%. So naturally, a 67 to 70% is better than a 30 to 40%. So would you kind of say that we can legally consider surgical treatment as the first line of treatment rather than a CPAP, or would you still prefer to advocate a CPAP trial as the first line before considering the surgical option?
Yeah, that's a very good question. I want to share with you that if the patient is a Friedman stage 1 with big tonsils, definitely surgery first. Okay, that one we agree. Yes. We're talking about those with Friedman stage 2, stage 3 that you're not so sure. Yes, then I will fall back on the age of the patient and the patient's personality. I share with all my patients that number one, that they should try CPAP. I use the word should, and that is free, and that there is a free trial for them as long as they're willing to put it on their face. And I also tell them upfront, full disclosure, that I give them all the papers, like the ones I presented, I actually print out for all my patients' handouts so that they can read it, and I highlight all the graphs and whatever so that they are in full understanding and full disclosure, so that they do their own due diligence as well. Because you must understand that these patients with snoring and sleep apnea, right, the age range is from like 20 to 60 to 70 years old. So I want to say that my personal cutoff would be about 60 to 65, that I try not to operate on them. Because if they're willing to use the CPAP for the next 20 years of their life, I tell them, why don't you just carry on? But those younger ones, like 25 years old, 30 years old, I think it's a bit of a stretch to ask them to use the CPAP for the next 50 years, especially if they are skinny, thin, with no weight to lose. Any comments, Vikas?
Totally agree with that. Though the anatomy in your country is different from the anatomy in our country. But I totally agree with you because there are a lot of anatomical issues that our patients are also facing. And possibly in the panel that I'm going to moderate, I'll be going on that aspect.
So we have come to the end of the first session now. Thank you, Dr. Pang. Now we will go on to the next session. That is going to be the panel discussion. And we are going to be moderated by none other than our famous Dr. Vikas Agarwal. He doesn't need any special introduction, but still I would just add few of his. He is the director of specialty ENT hospitals in Mumbai. He is the first surgeon from India who introduced the robotic sleep surgery. And he is also the first surgeon who performed the salpingopharyngeal fold reduction and published in international journals. And he is also the one who performed the first submucosal endoscopic tongue-based resection surgery, which I think he called it a smell surgery. And he is also the first surgeon who has innovated the suspension bridge pharyngoplasty procedure for palatal procedure. So I can go on and on about his achievements, but for the want of time, we would proceed with the panel discussion. Over to you, Vikas.
Thank you, Sagar. Actually, Sagar was just being too humble and he was enumerating. I have not really done so many things. Anyway, without wasting time, let's come back to our session for today, which is panel discussion on tips and tricks in OSA surgery. Now we have exactly 1 hour for the panel, and we have 6 panelists. We have Dr. Kenny Pang. You all have heard him right now. He's an excellent speaker, excellent surgeon, and he is the director of Asia Sleep Society in Singapore and a very famous international faculty in our field. Dr. Seema Sheikh from Pune. He is the founder president of our Indian Association of Surgeons for Sleep Apnea, and I believe In India, he does not need any formal introduction in the ENT circle. Dr. Vidyasagar from Vijayawada is our current president, and he has done a great amount of work. He was with Dr. Friedman earlier. In our country, he has popularized a lot of sleep procedure and done lot many workshops. The secretary of the association, the everlasting secretary, Dr. Vijay Krishnan from Chennai, a very, very active and enthusiastic person, very good in academics. And obviously, he also does not need any introduction. Rahul is a young boy doing very, very well in Mumbai, and he is trained from Stanford. And Dr. Sandeep Bansal is from PGI Chandigarh, is a professor in ENT and director of the sleep services at PGI Chandigarh. So, the most common fear in the mind of ENT surgeon before performing sleep surgery are three. First of all, because the sleep apnea patient is already, the airway is already compromised. So the airway emergency, which is created during intubation and extubation, is the most important fear in everybody's mind, including me. So this is one aspect that I'm going to elicit from our panelists today. The second aspect is bleeding in the airway, because you are operating in the airway, which the patient is going to use for breathing and swallowing and eating after the surgery. And if there's a bleeding in a difficult airway, it's going to be an emergency during surgery and after surgery. So second aspect is bleeding in the airway. And the third aspect is the major complication of palate surgery, which is regurgitation of fluid or change in voice. So I'll start off with because we have very limited time, so I'll be very, very short and quick. And I'll start with the airway emergency. So we all know that while dealing with obstructive sleep apnea patients, we are bothered about the airway. What will happen during intubation? What will happen during extubation? Will it be difficult? What all situations can arise? So how do we predict when we see a patient of obstructive sleep apnea? How do we predict that we'll have a difficult airway? So do we look at the body mass index of the patient? Do we look at the AHI, apnea-hypopnea index of the patient? Do we look at the Malampati score as we were just discussing? So I'll leave the board open. I'll start with Kenny. Kenny, when do you decide? How do you decide when you see a patient of obstructive sleep apnea? What is the thing that switches the red flag in your mind that this patient is going to be a difficult airway?
In general, I only use an anesthetist that I can trust. That's number one. Number two, I look at the patient's BMI. That's very, very important, because the bigger they are, the worse it is, definitely. I also look at the jaw size. The smaller the jaw, the worse it is. That's pretty much most of my, and of course the Malampati score. But I don't want to steal the thunder, so let's move on to the next panelist. Sagar?
And what about the AHI? If you see a AHI of 100 versus
AHI does not. AHI doesn't really determine the airway predictors of airway difficulty.
So this is a very, very important point. AHI is not the real predictor, because it's only the number of time more than 10 seconds the patient is either getting hypopnea or apnea. So if the apnea is of 50 seconds or 10 seconds, it will always count only one. Therefore, number of hypopneas per second does not matter. This is the takeaway point. Anybody would like to add on this point of AHI? Sagar, Sandeep, Rahul? You all believe that AHI is not very important?
Yes, absolutely not. Not for determining the difficulty in airway.
So if you have a patient of AHI of 120 with a body mass index of 25, will you be taking this patient very easily, or will you take it very seriously?
Like, I feel there'll be other factors, but just the AHI will not make any difference whether I would operate this patient or not.
Rahul?
Yeah, so one point we should get across is AHI is, if it has any role, it has more in defining the disease severity more than my surgical planning. Surgery planning is more about anatomical corrections and what are the challenges I may face. So AHI doesn't really impact. It at best helps me in defining the need for treatment, but not really in the surgical planning.
So, Sagar?
In other words, I would say that huge tonsils, just presence of a huge tonsils can cause an AHI of 100. but it may not cause that much of difficulty in intubation. So just don't go by AHI. It is just an indication for the disease severity, but the anatomy is totally different. You have to look into the anatomical aspect of the patient for determining the difficulty in intubation rather than just the numbers in AHI.
Seema?
Yeah, so I agree with everything that everybody said. For me, if you're talking only clinically, this is it. But my first examination always has a flexible awake lying down scopy. And that is what I use more to see the inside of the airway than just sitting down in a position and watching their oral cavity. So for me, when I put in that scope, that's when I would look at the difficulty of the airway.
Vijay, what is your take?
Yeah, same thing, whatever so far discussed. So I don't have any fresh points to add.
So now all the panelists agree that looking at a high AHI, one should not be really scared. So does that mean that AHI is absolutely useless? No, it has some uses. Well, obviously physicians have more use, but the anatomy, it does not correspond to the site of collapse. It does not make any difference in the difficulty of the airway for intubation extubation. BMI, as Kenny rightly said, is very, very important because BMI would result in a more air requirement by the patient. Let's come to Malampatti. We have already discussed that Malampatti really does not matter because you cannot see the base of the tongue. So anybody wants to add that Malampatti, what Malampatti score has any use in surgery when you have already done a DICE and you have decided this surgery is to be done?
I think the Malampatti is important for the anesthetists because they still use it until today. And it does give them a rough guide. May not be always true, but it does give them a rough. So the anesthetists use it all the time.
Perfectly, all right. So
I think
here you see that.
I think with the video endoscope coming in, I think Malampatti for anesthetists also doesn't make much of
has lost relevance. So as you can see here, this is a patient of BMI 32, AHI 57.
Before that, you have put on screen optimization, I think, because the screen, it shows some blank spots.
Okay, so I will not optimize. Now see it. Is it? One sec.
I think now it's going to be better.
Okay. So I'll not optimize. Just check out now. Is it okay now?
Much better. Yeah.
Now you can see this body mass index of this patient is 32, high, AHI is 57, also high, and there's no tongue-based collapse. Saturation is significant, but there's no tongue-based collapse, and you know that when there's no tongue-based collapse, so intubation is not going to be difficult at all. And on the other hand, this patient with a BMI of only 22 and AHI of only 10 still has a tongue-based collapse. So this point has been told by every panelist that we should not only look at the BMI and only look at the AHI, and BMI is important for oxygenation. So how to anticipate difficulty in intubation? What is the pre-operative investigation use? Is DICE the preferred investigation for everybody? If that is the case, then we'll move ahead. If not, then panelists, you can add. How do you anticipate difficult intubation if not Malampatti? Then is DICE the thing?
Shall I just move on? Yeah. So yes, definitely DICE is going to be one of the primary factors in deciding the difficulty during intubation. But during the DICE, we also should look into the skeletal structure as well, which is a part of our interventional DICE to see if the maneuvers helps us. Another important factor we have to see is the anterior positioning of the larynx. Your tongue base may not be that bulky, but if your larynx is anteriorly positioned, still it may become a difficulty for intubation. So that also should be taken into your consideration. But all this can definitely be assessed during your DICE, and your anesthetist will also be looking at the screen, so he will also know how the airway is, so he will also be prepared for it.
So basically, the takeaway point is that for anesthesia difficulty, the airway can be divided into two segments, the upper segment and the lower segment. Upper segment is the nose and the soft palate. The lower segment is the tongue base and the larynx or epiglottis. So if there's a collapse at the level of the upper level, then the moment you put an oral airway, the upper segment is bypassed and you can easily ventilate this patient. But if the problem is in the lower segment, then you cannot ventilate this patient once you give him anesthesia and the muscles are relaxed. So this is the most important thing. And as we all said that the lower segment of the tongue, the anterior 2/3 of the tongue does not contribute to sleep apnea, and you can assess that segment by Malam Patti, whereas posterior 1/3 of the tongue is more important for obstructive sleep apnea for intubation extubation, and that you cannot see by Malam Patti or Friedman's classification, and therefore a scopy, a flexible scopy, whether with Muller or drug-induced sleep endoscopy comes into place. Now, anterior 2/3, why it is important, as Kenny rightly said, that anterior to the base of the tongue, the anterior 2/3 of the tongue is important for the anesthetist because they are looking into the airway, and if the anesthetist is looking straight, anterior 2/3 of the tongue can be tricky. But if you have an angled scope, then obviously that is taken care of, and you can easily intubate the patient, whether the anterior 2/3 of the tongue is bulky or not, by looking at the laryngeal inlet. They can intubate the patient easily. This is a very, very important point because this is the most important thing by which you decide how your intubation extubation is going to happen. Because if you damage the larynx at this point of time, if there's a bleeding and you cannot put the tube in, it can be really dangerous. Now, the next question is that I'll again start from Kenny. If you have to perform nose and palatal surgery, will you do it in the same stage if the tongue base is not large? And if the tongue base is large, then will you? How will you go ahead?
Can you say that again? If it's a single stage nose and palate surgery, what's
if the tongue base is not large, will you do the nose and the palate in the same stage? If the tongue base is large, yes.
Sorry, I lost you. But yes, I do multi-level surgery in a single stage all the time. Yes, I'm a proponent for multi-level surgery, even if it includes the tongue. It's just that I'm very cautious when I do tongue surgery in the sense that I keep the patient in ICU if I touch the tongue. If I don't touch the tongue, my patients do not need to go to ICU. Maximum will be high dependency unit. If not, I do multi-level surgery and a single sitting all the time. Yes.
Perfectly. Anybody would like to add anything to this?
Just the fact that whenever you're doing the nose and palate together, we're ensuring now that the nose remains patent by not packing too much. We ensure that we either use the airways or use Z sutures or splints or whatever you may need to use, just so that you keep the nose open.
Because can I add a point?
Yeah, why not?
Yeah. So I usually was doing how we were traditionally doing, dice separately, then the nose and palate, and then the tongue base. But now recently what I have moved on is I'm combining the nose along with the dice in the first stage itself, which makes sense because almost 90 to 95% of our patients are actually having a nose block. And for that, we can combine it while we are doing the dice. So anyway, we get a CT scan for them. So that we have to do a dice at the OT or in the endoscopy room. So I take the patient for dice as well as in the nose in the stage 1. So there is no problem for me for whether there is a packing or not for when I'm doing the second stage or any other procedure. So that's how I'm doing nowadays.
This is what Sagar actually just said, that if you have a large base tongue, you actually do not perform the nose surgery in the same stage. You should have finished the nose surgery in the previous stage so that you have a patent nose for going through putting the nasal tube for base tongue surgery also. So I'll not like to waste too much of time here, as we have already understood that BMI and AHI do not matter at all for intubation, but they matter in extubation. High AHI, high BMI patients would require more oxygen supplementation, especially high BMI patients will require more oxygen supplementation, and therefore they have to be put into high dependency unit or this. Now, we all are working in different setups. Now, the questions are, is ICU setup must for every sleep apnea surgery? which cases can be done in daycare nursing homes, and when to do a tracheostomy. So panelists can start. Vijay, what do you say? In your practice, what kind of cases you do and in what setups?
We should have ICU facility, I would say. We don't know really which case we will get into trouble. And daycare, which cases can be done as daycare nasal surgeries alone if it is not a severe OSA kind of setup. And when to do tracheostomy all depends upon the BMI, how severe the multi-level collapse is, not AHA really. What kind of surgery, whether you are doing any facial-maxillary procedures, skeletal surgeries, how much edema do you expect in the post-op? What is so all depends upon that, whether you are going to keep the patient intubated for the next 1 day. So depending on all factors, I think the tracheostomy is being decided, not for every case.
Sandeep, you have a ICU at your disposal. So do you keep every patient in the ICU, or you do not keep most of the patients?
Most of the patients I do not keep in the ICU.
Not keep in the ICU. That is very important.
Yes, I'm not keeping in the ICU. I am not combining, doing a multi-level surgery, like all levels together. I'm doing a staged procedure. But recently, I have moved on. What Sagar was also saying, that I've started combining my septoplasty with DICE, so that at least the nose part can be taken care of, and then I can proceed with the palate and tongue base together, because the nose would be patent. And secondly, I do not recommend any daycare OSA surgery except just the nose surgery. I would not recommend any daycare surgery for OSA.
So I think the message is loud and clear that you do not require to keep every patient in the ICU. Large tongue bases, major maxillofacial work requires ICU, but you should always have a backup, because you never know which patient will not do well. Vijay, you wanted to say something?
Yeah, that's what. ICU, we are not going to keep every patient, but that setup should be ready, as you point out.
As a backup, yeah.
Perfectly, all right. So now we come to the point of how to prevent bleeding in the airway. We can have a lot of things, but the most of the time, tonsillectomy is the sine qua non of OSA surgery. And tonsillectomy is a very old procedure, but the only complication that every surgeon fears is the bleeding from the tonsil, right? So how to prevent tonsillectomy bleeding, especially secondary bleeding? See, primary bleeding, every surgeon will control. So I again may start again from, say, Kenny, how do you prevent a secondary bleeding from the tonsils? What is your technique of preventing a secondary bleeding from the tonsils?
Well, I don't think you can predict or prevent secondary hemorrhage. Sometimes it's just, the patient factors. It's very, very hard to tell. I think most of us who have done enough will know that you will always have that one very bad secondary hemorrhage that you never forget. In fact, now it's in my mind already. Yeah, so it's something that you can't prevent. But I do give my patients antibiotics for at least 2 weeks. And I also give them hydrogen peroxide gargles, I know it's anecdotal, but maybe you all can share whether you do that as well. And I know they say that you should avoid NSAIDs for pain during this period, but I've not found that there's any statistically significant difference between the usage of NSAIDs for pain to prevent secondary hemorrhage.
Any panelist would like to add any technique to prevent secondary bleeding? Because this is something everybody is scared of. Rahul?
I think if you are suturing, can I?
Yeah, go ahead, Sandeep, you finish.
Yeah. So if especially if you are suturing the mucosa from the anterior pillar and the posterior pillar finally, so lesser the raw area, lesser chances of secondary infection. When we are doing conservative or reconstructive surgeries like ESP or relocation, I think rather than UPPP, then the raw area is definitely much less and less chances of getting into secondary hemorrhage. Rest antibiotics and other things.
No, so I guess they've covered the points. The only thing that I could, possibly tell people is that, with all of us who work in the oral cavity, barring tongue base, and let's keep tongue base aside, most of the other bleedings are like, handling them on a regular basis. So it would only be a tonsil or anterior palate or these things which are in our vision. They are very easily accessible to us. So I don't think this is that big a problem. Tongue base, yes, major problem.
Anybody wants to add? Yes, Sagar, go ahead.
Yeah. So this is the protocol I follow. So even if we follow this, we cannot 100% escape sometimes, but still, what are the tips I would do is try to respect the tissue plane, whatever you can. Number 2 is at the end of the procedure, make sure the patient is in normotensive or a little bit even hypertensive before you extubate the patient.
Hyper.
Yes. Don't extubate in hypo.
Hypotension. That's a very, very important tip.
So let the patient's BP, if you have given a hypotensive anesthesia or some other medication, make sure it returns to normotensive. Number 3, allow a downtime. What is the downtime? You remove all your instruments out as the patient's mouth, everything keep in close position as normal as it can. And then once again, after 1 or 2 minutes, once again, recheck the oropharynx and see if there is any accumulation of any ooze or trickle or bleed or anything. If there is any raw surface, try to take control of it then and there. Number 4, if you have used any gadgets like a coagulator or a radio frequency, it is even more diligent for that because small microvessels get bipolarized with your coagulator or radio frequency. And if there is a big vessel, slightly it may get controlled at that time, but when you're done with the procedure, those may open up. So when you're...
This is what I was actually, the slide was meant for this, Sagar, you nailed it. Anybody wants to add?
Number 5.
Because you can also add the concept of tonsillotomies nowadays.
Yes. Number 5 is, I was about to say that. Number 5 is, if by chance your OSA is not being contributed by the lower pole, you may just leave a little bit of tonsillar tissue over the tonsillar artery. That is only if you may. Just make sure that it is not contributing for any of the collapse in your dice. If so, you may leave that. Number 6 is sometimes while you are finishing off the surgery, you may notice that the patient is about to come out of the anesthesia. At that time, you also notice if any oozes are coming up. If so, you can also control it. It's almost equivalent to the first point that I have mentioned. So these are the 5 or 6 points I want to mention.
Yeah, Vijay.
Yeah. So whenever you see any exposed vessels, especially the paratonsillar veins, so you can better to coagulate rather than leave it open, or even better to do ablation on a superficial space than using a blue pedal often. And as Sagar rightly said, we always call it as anesthetist bleeding, where when they put the scope inside, they will find out, sir, there is some bleeding in the sanguine. So, as he rightly said, so after removing all the instruments, leave it for some time and then have a second look. If there is any bleeding, we can bipolarize it or cauterize it. And we have to respect the tissue plane, as he rightly said. Less trauma to the tissue, lesser the infection and lesser the bleeding. So I think all the points have been nicely covered.
Now, which is the most important artery? The lower part, the tonsillar artery is the most important site of bleeding. So if you damage the main tonsillar artery, the bleeding will be more. If you damage a small branch, the bleeding will be less. So the proximal the damage, the more the loss, more the problem. So as Vijay rightly said, paratonsillar vein is benign. If you see a vein, you just coagulate it and leave it. It will not bleed as secondarily because it's a very low flow system. It will just stop by itself. But if it is an artery, it will keep on pulsating. The artery will keep on pulsating. There will always be a flow coming from the tonsillar artery into the branches that go into the tonsil. So if you catch the tonsillar artery here, behind that block, there will be always a pulsation. And the proximal it is to the heart, the more the pulsation it will be, like this. So with this pulsation, that coagulum that you have formed is likely to break, and that will cause bleeding more in the proximal part than in the branches. And therefore, like Sagar earlier said, you can do extra capsular surgery at the upper pole, because upper pole is responsible for sleep apnea. The lower pole is never responsible for sleep apnea. Never. We have done, we would have a collection of around 1,000 dyes. Lower pole of the tonsil never comes closer to form, for sleep apnea. So you need not remove the lower pole. You can leave a very small amount of tissue at the lower pole by doing an intracapsular surgery. And even if you have to remove the whole tonsil, then you can pull the lower pole and coagulate along the course of the tonsillar artery like this. Now, this is this.
In an infected tonsil, if we leave behind a lot of tissues, then she'll still have some problem in the post-operative period. So I'll not leave behind lymphoid tissues, but at the same time, I'll make sure that it does not bleed in the post-operative period also.
Coagulate along the course.
So I'll coagulate this whole area along the length of the proposed tonsillar artery, and then dissect at the medial aspect of that length.
So this is one more tip, apart from all the panelists that told you. You can coagulate along the length and then cut at the medial aspect, then your bleeding chance will be much, much lower. Now, just one slide on the tongue-based surgery. Sagar, what precaution you will take to make sure that the tongue base does not bleed after, say, 10 days or so, 7 days?
Yes. Yeah, very good question. Because I think knowing the anatomy properly. Number two is, while using your wand, you should not directly use the wand like this on the tongue base. Instead, you leave a small gap between the tongue base and the wand so that the suction doesn't apply directly and it will not start to ooze during the procedure or at the end of the procedure. Number three is the accumulation of coagulum or the exudate post-operatively. And number four is, if by chance your anesthetist has to intubate, that is going to be a very big headache. So make sure, if you're dealing with a muscular tongue base or a lot of resection has been done, make sure you keep the patient intubated, check with the endoscopy the next day, and then extubate. Otherwise, if there is any ooze while the anesthetist introduces the laryngoscope into the valvula, that is going to cause the injury to the raw surface, and that may cause bleeding post-operatively. So these are some points that we could think of.
Very, very important. Anybody wants to add anything? Sandeep, yes? I think Rahul, I cannot see you on my screen. If you want to add anything, just say out. Huh? I cannot see you on my screen. Yeah.
Right, sir. So just a couple of points, most so in the post-operative period for these patients is, all these patients, a lot of them may have high blood pressure. So good control of blood pressure post-operatively in terms of their medical compliance, because their diet anyways is going to be compromised. Some of them may have the notion that wo kha nahi rahe hain, so if they are not eating enough, they cannot take their pills. So that is one. Second is, my experience with secondary bleed has been bad in 2 occasions, and both those occasions, I think the blame was on the potato chips, because of the sharp edges of the potato chips, kind of like, cutting across the raw wound areas. So I right now have started making a special mention that all that is eaten should not have any sharp edges. So toast, potato chips, and khakras and papads. That's like some basic points that I tell to all the patients and the caregivers, that for at least 7 to 10 days till the entire raw surface heals, nothing with sharp edges. So those two
very
things.
important point. Very, very important. Sandeep, you wanted to add something?
Yeah, I just wanted to say that if we keep our field of dissection in between the 2 tonsillar arteries,
very, very
ultrasound.
Absolutely bang on. You do not have to go laterally, because it's only the central area, and where the main arteries never come. It's only a profundolingual artery which comes over there. So Sandeep has really made a very important point. If be in the center, center is least vascular, and on the side, you really need to do not need to resect so much. So I think very nicely made. Now, all of us agree that coblation is the best technique, tool for performing these surgeries. And we know that too much of irrigation, too little irrigation, too much of suction, and too much of suction, too little suction cause problem. So any of the panelists would like to add anything? How you make sure that what is the correct amount of irrigation, what is the correct amount of suction? Do you want to make any point? We know that it has to be adequate. Too little of irrigation will incomplete the electrical path. Too much will again create a problem. Too little suction will create a problem of clogging. Too much will extinguish the plasma. So how do you get that accurate? Is it only by experience? Can I start with Kenny? Your experience on coblation. So how do you decide how much irrigation is the perfect irrigation? How much is the suction that you keep?
I think it's an experience that most surgeons will pick up along the way. I don't particularly have any particular suction pressure that I'm paranoid about, but I use coblator like every day. So I want to say that, it really, it's your comfort level. I don't have a specific number or a sign that can tell. Yeah.
Let me ask you, how much time did you take before, getting adequate results from the coblator? Because I think I almost 30, 40 surgeries down the line, I got the hang of how much is the exact thing. When 12, 13 years back, I started using coblation. It took me 30, 40 surgeries. Was it the same for you? You took some time?
Yes, it's pretty much the same. That is correct. With the adenoids as well. Yes.
So basically, what I wanted to impress is that people buying coblators should not be in the impression that the tool will do the surgery. Ultimately, it's you who will do the surgery. And how to use the tool is time consuming. So you must respect the learning curve, learn from your teachers, the experts, and then you will become expert in this. Yeah,
Sandeep wants to add something.
Yes,
yeah, I just wanted to add one thing, that it will also depend, like the suction and the coagulation or ablation mode, whatever you are using, would also depend upon the wound you are using. Whether it is a EVAC or it's a EZ view or it's a ProSize Max. Like I use a EZ view for my tonsils rather than a ProSize or a EVAC. I find it to be balanced between a EVAC and a ProSize Max.
Perfectly. So now we come to the most important thing that every surgeon is worried about: how to prevent complications of regurgitation and voice change while operating on the soft palate. Because soft palate is the most common surgery that people perform for obstructive sleep apnea. So now the video that I'm going to show is showing that the snoring and the sleep apnea is happening from, I'll play it again. Sorry, it got stuck. It happens at the base of the uvula. So my question is that, I think it has got stuck. I'll have to stop sharing for a moment. Are you able to see me? Because my thing is totally stuck. Vijay?
Yeah, we can see you. So your Zoom is working.
Sorry?
Your Zoom is working. So we could see you.
Okay, so my computer has got stuck actually. Yeah, I got it now. So the question is that, is it always important to preserve uvula? Because if you preserve uvula, then how will you eliminate snoring? Because snoring is happening from the base of the uvula. So I'll again start from Kenny, because see, right now across the globe, everybody is saying that you must preserve uvula, but you see this base of the uvula is here and the tip of the uvula is there, and this much of the tissue is actually collapsing. So is uvula preservation a must? Kenny?
No, it's not a must, but I would always try to leave a little bit, like to create a new uvula behind. The answer is yes. And sometimes it's causing more scarring laterally in order to make the scar taut so that the palate does not vibrate so much. So although, yes, I find that the uvula many times is the culprit of the snoring. So by reducing it and creating a smaller one, it helps a lot.
Okay.
And I always tell the patient that there will be a bit of change in voice, and maybe if we do a extensive surgery like Zeta, we tell the patient there may be a temporary nasal regurgitation. So we better to explain the patient to make them understand what is the complication or what do they expect.
Anybody wants to add? Sagar?
Barring Zeta, it's a different issue, but it's a very standard thing that if you want to prevent nasal regurg, make sure you're caudal to the dimple. So you put in and you palpate and you push the soft palate down till where you hit the posterior pharyngeal wall. And you make sure you're caudal to that and not cranial. So that way your regurg will not happen. But like Vijay said, yes, in a Zeta, when you're actually opening that and pushing it around like a book, there is likely to be temporary regurg that the patient needs to know about. And the second part of it, if you're asking as far as uvula preservation, so preservation is not a must, but yes, we do tend to preserve it. So it's not a must. But once you are caudal to cranial to your dimple, then there is probably no need for you to remove that much of, or the entire uvula. You can partially remove it and leave it.
Sagar?
Yeah.
Take on uvula.
So I'll answer all the three questions. As Vijay told, almost all of the patients will have some amount of change in voice or the speech. We are going to alter the pharynx. So definitely, if it is a singer's, professional voice users, it is our duty to inform them prior that they would notice some amount of change in voice or speech, not voice, the speech. Coming to the velopharynx, even in Zeta, we have techniques to know that the patient will not have PPI. At the end of the procedure or in between the procedure, we can pass the endoscope and press while suturing and check if it is actually touching the posterior pharyngeal wall or not. If it is going to touch, then the patient will not have velopharyngeal incompetence. But if you have done so much of resection and opened it so much, then obviously when you are going to press it, your posterior pharyngeal wall is not going to meet it. So that patient will have either a temporary or a permanent velopharyngeal incompetence. So as our previous panelists have all told, we have to respect the Lakshman Rekha, that is the palatal aponeurosis. We should not do any resection above or cephalic to the palatal aponeurosis. Number three, regarding to the uvula resection, majority of the patients whom I see or we see in our country have thick, bulky uvula and soft palate. So we have to remove it to give a better result for them. So I think the only disadvantage of removing is going to be that foreign body sensation post-operatively. Apart from that, I don't think the patients have any other problem by removal of the base of the uvula. So for me, if the patient is having a significant collapse at the level of the velopharynx, which is contributed by the thick and bulky uvula and soft palate, I would not hesitate to remove it, but I will try to see if I can reconstruct an uvula if possible. Number four, I will never ever combine surgery on the posterior pharyngeal wall, like for example, an adenoid and palatal surgery on the same sitting, because if there is a raw surface on both sides, then there is a chance of velopharyngeal stenosis. So that also should be done cautiously. Or if by chance you're using a debrider or a coblator, make sure your posterior surface of the uvula and soft palate is not having any ablation or any energy introduced into that.
Perfect. Anybody wants to add anything? Yes, I think Sandeep.
Yeah, just one thing about the uvula reduction, I would say. Maybe if you don't want to sacrifice the whole of uvula, trimming the uvula as Dr. Kenny suggested, and maybe volumetric reduction at the base, submucosal volumetric reduction at the base with your wand would do the trick for the, and further scarring would take care of the vibration, I think.
Very nice. Who wanted to add? Anybody wants to add?
One point, sir.
Yes, sir.
So again, it has been my experience, a vast majority of the patients will have or have a tendency to develop a temporary VPI. So I generally counsel them that at least 7 to 10 days they may have up to 15 days, but typically most would settle. And being more conservative in the midline and a little more aggressive in the laterally is essentially the dictum that I follow when doing palate surgeries for these patients.
So as we have the take-home message is that if the uvula is really bulky and is contributing to obstructive sleep apnea, our primary aim is to remove the obstruction. And for that, if uvula removal is required, everybody is suggesting that it can be removed. There's no big change happens apart from little foreign body sensation. So let's understand what happens when the person is having sleep apnea. This is how the tonsils and the soft palate is moving behind. And this is the action of the tensor palati muscle. You can see that the uvula, the base of the uvula is here. The tensor palati is much, much anterior. And the most important muscle, levator palati, is also much anterior. So as long as you do not damage the palatal aponeurosis, which is being pulled by the levator palati, even if you resect the uvula from the base, I would have possibly removed maximum uvula on this earth talking to surgeons. I left, right, and center and removed the uvula. There's no voice change at all. Yes, in singers, there is little change because of the pharyngeal disturbance, but uvula removal is not, it's not a crime. Because if the base of the uvula is responsible for snoring and sleep apnea, you might remove uvula. Most of the surgeons try to preserve uvula because if you're a little too aggressive, then you can give velopharyngeal insufficiency. But if you leave a sufficient length by, like Kenny said, and Sagar said that you push your finger and see where it is touching at the back. If you leave sufficient length, nothing will happen. Now, what is important is to understand that the blue line is the level of the levator palati. This is the level of the levator palati muscle, and sleep apnea happens at the lower end. So swallowing happens at the snoring happens at the lower part. So you need not bother about that. So this is therefore everybody said that uvula can be removed, but you should try to preserve it as much as possible. Now, let me start from the junior most. Rahul, what is your preferred palatal surgery technique? You have started the most recent, so obviously you have seen everything before starting.
You are mute.
So palatal surgery would depend upon more on the type of palate, whether it's a thin palate or a thick palate, and a little bit also on the dice findings. So typically I use either a relocation or I'm a big fan of Dr. Kenny Pang's technique. So more like the functional ESP rather than the open ESP. If it is slightly thicker palate, but for thin palates, more of a relocation pharyngoplasty. So combination of these.
So your surgery decided on the look of the soft palate or on the type of the collapse you see on the dice?
So both actually. If the soft palate feels very thick, then something like a relocation won't work for it because relocation, works better for thinner palates. And it's just a look or feel of it. As much as I would like to objectify it, it is more like, how I feel the palate is looking. So if it is looking thicker, bulkier, then I'll require a little more aggressive procedure. Relocation, otherwise for thin palates is what I go. I will add typically an anterior palate procedure, something like either a partial uvulectomy or a proper uvulopalatal flap if I feel there is a significant anterior component along with it also.
Sandeep?
I prefer my modification of relocation. Then the thickness of the palate doesn't make any difference. The two modifications I do. And if there is a circumferential collapse on dice, I would add anterior palatoplasty to my palatal surgery.
Okay, Seema?
So mine would depend on whether I have a vertical palate or an oblique facing palate. So if there's a vertical palate, I won't really try to get too aggressive. I would probably do simpler procedures like somnoplasties or whatever, because it's not going to affect the AP collapse part. If it's an oblique palate, then based on whether there's a lateral collapse, how much is it? So I've kind of evolved from, let's say, anterior palatoplasties to expansions and to the bow. So the lot would depend on whether I have a vertical or an oblique palate and the thickness of the palate. So an extremely thick palate obviously is not going to be beneficial with this. And an extremely thick palate with a circumferential collapse, there is no brainer. Then I think Zeta is the best procedure for that.
Vijay, what is your preferred technique?
Yeah, depending upon the pattern of collapse and the type of what we have discussed so far. So my favorite is Zeta and functional expansion sphincter, rhinoplasty, as Kenny Pangs discussed. And if needed, I will go for maxillomandibular advancement if there is a vertical palate and along with tongue-based collapse with the retrognathia, etc.
Sagar?
I would agree with the previous panelists that it all depends on the palate type of the collapse, severity of the collapse, and the type of the uvula and thickness of the uvula and the level of the obstruction. So in our setup, where I see majority of them comes with circumferential collapse and they are having thick and bulky uvula and soft palate. So for them, I would either most likely do a Zeta palatoplasty, but by chance, if they have a thin and flimsy palate, then I would opt for a expansion sphincter along with anterior palatoplasty. And obviously, if there is a tongue base, I would combine the tongue base.
Yeah. Kenny, what kind of palates you see in your practice?
If it's a lateral wall collapse, I do the expansion. If it's the anterior posterior collapse, I do the anterior palatoplasty. Concentric, I do both the anterior palatoplasty and expansion technique. If there is very thick posterior webbing, I will do a lot of lateral cuts as well, just to scar it, to hold it up. I do not use the Z-plasty. I do not do relocations. I do barbs sometimes, but I favor the expansion technique over the barb, definitely. Yeah.
So in your country, do you see very thick palates as Sagar sees in his practice, or you see very thin palates?
I see the whole spectrum, Yeah, I do.
So the takeaway point is that there are almost 30 types of palatal surgeries. Few of them are most common, and again, in them also, you saw that every panelist has a different preference of doing a particular surgery. Therefore, the new surgeon who is watching this webinar should not go away with the idea that he'll learn one surgery and start doing that. He has to understand the philosophy of this surgery. Now, my question to the panelists is that, have any of you thought of going across the palate from the midline from one side to the other side? Because everybody feels that, Rahul said that you work less in the midline, more on the sides. If you work more in the midline, everybody feels that there will be regurgitation. And actually what happens is that in this, my suspension bridge technique, I go across the midline and nothing happens. Why? Because I go at the level of the, the anterior pillar to anterior pillar line, which is below the line of the levator palati and the palatal aponeurosis. So there are so many things in this field is evolving. We should not go away with one thought in mind. And in my hands, going across is working very, very well. And the snoring almost goes away, sleep apnea almost goes away in most of the patients, while I go across from one pterygomandibular raphe to the other pterygomandibular raphe. So the viewer should not go with a fixed idea. You have to learn the philosophy of palatal surgery. The field is still evolving. We all have different ideas of how to deal with things, and then accordingly we treat the patient. Now, our session is coming to an end. I have a limited time. I have to keep 10 minutes for question and answers also. So a very, very big problem that I keep on facing, and I'll ask all my panelists, there are a lot of patients who are actual mouth breathers. Now this patient,
what you see here is the patient is used to mouth breathing in spite of his nose being wide open, still his mouth breathing. Now we'll observe what happens when you close the mouth. This is his palate completely collapsing with the mouth open. Now I'll keep the mouth closed and see what happens. His apnea converts to snoring immediately. His breathing becomes better. So whatever you do on the soft palate is still not going to completely improve him if you do not.
Now see, this patient had almost a turbinectomy performed somewhere else, and he comes with sleep apnea, severe sleep apnea. The moment you close his mouth, it comes to snoring. So do you get these persistent mouth breathers? I'll start with Kenny. Kenny, you very rightly said that nose is the most important thing for sleep apnea. That's maximum of the time. That's the primary cause of airway resistance. So when you open up the nose, many of patients are still mouth breathers. Do you get such kind of patients in your practice? And if yes, how do you deal with them?
Yeah, it's pretty common. So these patients are just habitual mouth breathers. So what I do for them is I get them to tape their mouth with 3M 2 inches surgical tape, or you can get them a chin strap. That will also help, just for 1 month, and then get them to sleep on the side. It also helps, and after that they get much better. But so ensuring that their nose is clear.
Nose is clear, yes. Anybody wants to add on this? Persistent mouth breathers, Sagar?
Yeah. So I agree with Dr. Pang, what he has said. Apart from that, we also have to look at the palate, whether it is a high arch palate or not. If the patient is having the high arch palate, no matter how big the turbinates you have done or opened the nose, still the patient is going to have mouth breathing. So that we have to take a look, and we have to work with our dental colleagues and see if we can do any rapid maxillary expansion or not. So if we can do that, that is one thing. Another thing to address the habitual snoring or the habitual mouth breathing is putting a chin strap or putting a stocking around the jaw and trying to get them work on it. And number 3 is, if it is a pediatric age group, we try to ask them to give a small popsicle stick or something, so that purposefully they will have to keep the mouth closed to keep the stick in their mouth. So that way they will breathe voluntarily.
Daytime, not during sleep.
So
during daytime, no? Not during sleep.
Not during the sleep. The habitual mouth breathers or even daytime mouth breathers. So we can just break the cycle.
Sure.
So I have started giving them oral myofunctional therapy to improve the facial musculature tension.
Very nice. Is it working?
Yes.
Yes.
So especially in children. For adults, it takes much more time.
I also wanted to add that very important point, because that's something which is really coming up big, and we need to be looking into this myofunctional therapy. In fact, you'll have a lot of questions probably from people who will ask about myofunctional. They talk about yoga or things like that to improve their breathing issues. So myofunctional comes in a big way in that sense.
Very nice. So this is a very important take. Yeah, Sandeep, you wanted to add something?
I beg to differ about myofunctional therapies. I think it's more of a fad these days. There was a thesis done in our department. Nothing much came out of myofunctional therapies.
What was the thesis topic then, Sandeep?
The improvement in OSA out of myofunctional therapy,
No, so we are talking not about improvement in OSA per se. We're talking about improvement in the persistent mouth breathers and persistence after the OSA surgery.
Correct.
So there's a big difference. I'll leave it to Vikas whether he wants to take this forward.
That's fine. That's fine. We understood that for persistent mouth breathers, we have to give chin straps, we have to do myotherapy, whatever. But this is the big problem that we have to understand, and we have to deal with it, because our surgery, howsoever beautiful surgery do, will fail if the person is still breathing through the mouth. And I think I'll have to stop here because
Rahul wanted to add something.
Yeah.
Yes.
So just a quick point regarding persistent mouth breathers. I strongly feel that we should send a message that it's a habit that people acquire during their formative years in their childhood. So any kid that we are taking up for a TNA, especially in the younger years, we should ensure that they don't remain mouth breathers after the surgery, and get a friendly dentist on board, and they do a very good job with myofunctional therapy in children, and they have these myobrace appliances which helps the children break this habit. So in adults, it's a very big challenge, but in children, especially before the age of 10 and 12 years, if you work aggressively, you can really help them get over this habit. Otherwise, our efforts will fail and they'll become adult snorers.
So this brings to the point that in small children, Rahul, the nose is blocked and there's a grossly deviated septum, say turbinate hypertrophy associated. It's a structural issue. And we still say that we'll do septoplasty after 18 years. By that time, child develops a bad mouth breathing habit.
Yes.
So we have to, propagate that if septoplasty is required, do it early. The youngest child I have done a septoplasty around 16 years back when I was very new in my practice. The child was 4-year-old. Bad septum, 4-year-old I had done a surgery. The child has become an engineer now. See, if you do not, that was too much of a thing to do. But at the age of 12, 13, why should we ask the child to wait till the age of 18 years? And through all of you, I want to spread the message that open up the child's nose at every cost. Don't bother about the shape too much. Learn a little bit of rhinoplasty, learn about the growth centers, and you can do a good functional, nose surgery at a very early stage.
Most commonly in these children, the septum is bending because of the inadequate space.
Yes.
So even if you widen the maxilla and if you increase the space, so the maxilla will come down.
Yes.
That will increase the space for the septum to grow.
True.
Perfectly. Okay. Yeah, Sandeep.
Just wanted to. Didn't want to give a wrong message. Myofunctional therapy in a children to prevent mouth breathing is totally different thing. That is to be done. I'm talking about myofunctional therapy for adults, 30 years of age. I don't think so it works.
That was the point that I was trying to bring out. We can't rubbish that away. It was really helpful in this segment of patients that we're dealing with.
But that is for the children, not for the adults.
Exactly. That's what the discussion was.
Now we have a question from Dr. Indu Varsha from Karnataka. Good evening, sir. Most of the children post-operatively, post-tonsillectomy would not comprehend with gargling. So is there any cutoff age for surgery that we can do tonsillectomy? If it is okay, can we postpone the surgery for kids even if they are presenting with symptoms of OSA? So this brings to the point, after tonsillectomy, Kenny said that he prefers to give hydrogen peroxide gargles. So I also personally prefer to give hydrogen peroxide gargles. I believe all of us in India actually prefer to give hydrogen peroxide gargles. If anybody differs, no. So if the child cannot do gargling, is gargling a must after tonsillectomy? Panelists, any of you can add.
I don't use gargles for children. In fact,
Yes.
I don't see post tonsillectomy bleeding in children. It's very rare, It's very rare.
What is the age after which you will perform a tonsillectomy?
I can do tonsillectomy 2 and above.
2 and above.
Yes.
Wonderful. Is that intracapsular or extracapsular?
Extracapsular.
Very nice. I perform tonsillectomy intracapsular for very small children, and Kenny actually does it. You use coagulation or anything else?
No, I use monopolar and bipolar.
Oh, very nice. And with that, the children do not have problems with pain and eating and all, and you do not need to give gargles.
No. In fact, children are more resilient. I find that their pain threshold is really much higher. They don't feel much pain actually. Yeah, it's the adults that are a little bit more, Yeah.
So any of the panelists would differ with this? So the message is that you can do tonsillectomy if you are as good a surgeon as Kenny. You can do extracapsular tonsillectomy with a bipolar in a 2-year-old child. But if you're not as good a surgeon as Kenny, please do not do this. This will be a misadventure for most of the youngsters. So please do not carry this home from this message. Kenny is like more than 20 years into practice and is extremely good surgeon. Most of us will do tonsillectomy at what age? Starting from, say, Vijay?
3.5 I have done.
3.5.
Yeah.
Commonly?
Commonly
5?
around 6 to 7.
6 to 7. Sagar?
3 and above. Extracapsular, less than 3, intracapsular. Common age 4 to 5.
And gargles or no gargles after the surgery?
I would try to prescribe goggles, but many times it doesn't. They don't. So if they're older children's, yes, they would try to do it, but if not, no. So what I do is, I ask them to give some honey, Manuka honey, and that is both antiseptic as well as the pain reducing effect. So that's what I do.
Yes, majority of them above 3, but I've done tonsillectomies less than 3, between 2 and 3, severe, huge tonsils with adenoids, severe OSA. So I had to do.
Intracapsular or extracapsular?
Extracapsular.
Extracapsular. Rahul?
So 3 and above, typically, the youngest that I've done is a 2.5-year-old, but generally 3 and above. The 2.5-year-old had severe symptoms, and he was actually a pediatrician's son with frank OSA symptoms. So we thought of going ahead. And as long as the patient is eating well is my criteria. I mean, as long as the muscles are moving, I feel that there will not be much slough formation there, and the chance of bleed will be less. So gargling is a difficult call below the age of 5-6 years.
Correct. So we all agree that gargling is not a must to perform tonsillectomy. And intracapsular surgery is a much safer alternative if the child cannot gargle, but in expert hands, you can go for extracapsular surgery as well. So if the small child comes with a bleeding from the lower pole of the tonsil, how serious you think can be the issue if the child is, say, 10 kg, 9 kg, 8 kg and all? So those who are performing extracapsular surgery for a small child, there's a chance of bleeding from the tonsillar artery secondarily. So have you got any situation like that? Because then the tolerance for blood loss is very, very less.
See, you want me to?
You never got a situation like that.
So,
yeah,
no.
That's what I have.
So my impression is, so my experience has been, see, majority of these instruments, they work on the diameter of the blood vessel. So generally younger kids have smaller blood vessels, and that's why the coagulation and all is much better. And I keep a very low threshold in actually putting a tie at the lower pole. Frankly, I always prefer in putting a tie or leaving a small tonsillar remnant there. Whenever in doubt, if it is a bulky tonsil, always put a tie. When in doubt, put a tie at the lower pole. And touch wood, so far, the bleeds that have happened only in older kids like 10, 12, 14-year-olds, but not so much.
Very, very important point made by Rahul. See, in the younger kids, the blood pressure is less. So if the blood pressure is less and the vessels are small, it will not bleed. So see, that's why the philosophy of this surgery is that if the blood pressure is less and you have coagulated only the small vessels, it will never bleed. So therefore, Kenny has done in 2-year-old, Rahul has done in 2.5-year-old extracapsular surgery. So that's the take-home message. If you understand the philosophy and you have the control over your instruments, you can do a tonsillectomy at a very young age, Dr. Indu Varsha. And even if the child cannot gargle, ask him to drink a lot of water. The water will take away all this stuff inside and the wound will not get infected. I think Kenny wanted to add something.
And no, I was going to say that the solution to pollution is dilution. The solution to pollution is dilution. So you just need to drink a lot of water, like you said, and the bacteria will be flushed down.
Very nice. Sima, you wanted to say something?
No, so I think what I understood from her question was the fact that how much significance to give a kind of post-operative bleeding. And I think the message should be very clear. It is not to be taken lightly. If you have a patient, you make sure that you get them admitted, you have them under observation. Irrespective of whether they settle down or not, they have to be under observation. Don't take that lightly. I mean, if that was the question.
Yeah, Sandeep, you wanted to add?
I just wanted to say that it will depend upon the indication for what you are doing a tonsillectomy, I would say. If it is for recurrent tonsillitis, we cannot afford to leave any lymphoid tissue behind. So it has to be complete extracapsular. But if it is just for OSA, then you can leave a small remnant of tonsillar tissue at the lower pole so that you don't expose the tonsillar artery.
And how many of you do it surgery for tonsillitis at that young age? We always do it for OSA, most of the times.
No, above 3 years, above 3 to 5 years, yes, we are doing. Less than that, definitely only for you.
Perfect. So fine. The next question is from Dr. Tejasvi Gupta from Uttar Pradesh.
Because before that, there is one more question related to our discussion from Cape Town. The last question which I have put.
No, you read it out.
From Asghar Karjekar from Cape Town. Greetings all, and he wants to know what's the dose of hydrogen peroxide gargle what we use for adults.
So generally it's a 50% dilution. The hydrogen peroxide, which comes in 6% weight by volume, is to be diluted half with water. Is that what we practice? Anybody else has to differ?
I have no idea about the percentages, but it's in 1 glass. We put 1 cup of hydrogen peroxide and we give it to them to gargle.
Kenny, what is your concentration?
I dilute 50-50.
50-50.
Yeah.
Fine. So we move to the.
I dilute, as Simab said, 1 teaspoon or 5 ml in half cup warm water along with betadine.
With betadine, okay.
Betadine gargle.
So you do not want to get those, bubbles.
Okay.
Fine. So variation is there. At KM Hospital around 22 years back, I was trained that way. Use half and half. So I've been using half.
How about Sagar?
Sagar?
I use 50-50. 50-50. That's what I use.
Okay. So next question is that what is the chance of recurrence after OSA surgery? Now, it's a very, very open question. Kenny, how would you answer this question? What is the chance of recurrence after OSA surgery? It's a philosophical question.
I want to say it really depends on what technique you use and what sort of patient you're dealing with. Because, for example, if you have a patient with very high BMI, your success rate is already low to start. So you have to counsel this patient preoperatively to let him know that he really needs to drop his weight in tandem with surgery. If he's not planning to drop his weight, then please don't operate on this patient. If he's the sort of guy who travels a lot, he loves drinking whiskey and alcohol, then don't operate on this patient because he's just going to say, hey, doc, I want you to fix me and I'm not interested in my health. So don't operate on this patient. The success rate is very low. So if you can choose your patients carefully, choose your surgical indications, the correct anatomical sites that you're operating on, the success rate can be quite good. The answer is yes.
Very nice. I mean, that's a very great message. If anybody has to add anything, like Kenny said, that type of surgery, if you do any kind of tightening surgery, it will lose its sheen in 6 months to 1 year's time. Any kind of stiffening procedure will not last forever. So if you have excised anything, it cannot grow back. Now, if the patient puts on a lot of weight, there will be recurrence. If you have done a stiffening kind of a surgery, it will come back. So these are the two things which come to my mind. And as the age progresses, the muscle, tone will go down. So the sleep apnea is going to come back after certain years. Anybody has to add anything to that?
I think it's all about the counseling, because if you're doing multi-stage, you can never call that as recurrence. And that's the first thing in counseling that you'll have to do. If you're doing single stage multi-level, then I think that's where the issue of recurrence may come up immediately. But if you're doing multi-stage, I don't think you should even consider that as recurrence.
Now there's a question from Dr. Vidyadharan from Chennai. Is there any OSA surgery technique that targets the parapharyngeal fat pad area at the subglosso-supraglottic level? Subglosso-supraglottic level. Otherwise, is there any better way to reduce it besides exercises? Anybody is aware of any technique that targets the parapharyngeal fat pad area at the subglosso-supraglottic?
Yeah, the technique I would say is to lose weight.
Exactly.
So, Dr. Vidyadharan, so obviously there's no established procedure for the area that you have asked.
I think because the technique what we do with the coblation, it also addresses the subglosso supraglottic fat in the tongue base at least, you know.
Yeah, but he's talking about the parapharyngeal
but
fat.
not the parapharyngeal.
Yeah.
No.
It doesn't come into picture also, I think.
We only go into the vallecula. We do not go beyond.
Yes.
Right? So I think
the parapharyngeal fat pad plays a important role in constriction of the pharyngeal airway.
Fine.
So weight reduction is the only option.
Time is over. I hand back my time is over. I really thank all the panelists from the bottom of my heart, Dr. Kenny Pang, Sagar, Vijay, Sandeep, Rahul, and Seema. So thank you very much for being here. And I hand back the session over to Dr. Gautam Khan, the president of the IAOHNS. Sir, I hope the session was okay and was over in time.
Thank you, Vikas.
Thank you, Dr. Vikas. It was an excellent session, and I know you will do wonders when you perform. I mean, and all the panelists have, I think it was very informative for all the listeners. And thank you, Dr. Kenny Pang, for sharing your insights with us. I hand over to Vijay Krishnan, the Secretary of the Indian Academy, to wind up the session.
And also, I would like to thank Dr. Kenny for immediately accepting the invitation for it is very nice to hear from horse mouth about the expansion sphincter pharyngoplasty after a long time. Thank you very much, Dr. Kenny, and Dr. Vikas for the wonderful moderation. Thank you very much. And I would like to thank all the panelists for sparing their time on this Sunday evening. Thank you all. And at the outset, I would also like to thank GSK, especially Mr. Keshav and Mr. Shankar, who also put all their efforts to bring more than almost 890 delegates on this platform to watch on the Sunday evening. Thank you very much. Thank you all.
Thank you.
With this, we close our session. Dinesh?